those of you that know me, know I could talk for an entire week about continuity of care, but that means we wouldn't get any dinner and we wouldn't get any sleep, and that wouldn't help us very much. And so for today, I just tried to think about what would be the most helpful thing for us to talk about in this very short blip of time that we have to cover one aspect of continuity of care. And I thought the helpful thing for us, because it's quite controversial at the moment, is around the staffing and around the building blocks, just to help us get our heads around that question. Now, I'm going to be around all day, so I won't cover everything. I'm going to kind of zoom over this at record speed. But anybody that wants to talk about details, information, or dare I say it, the maths of staffing, which there is maths of staffing, believe it or not, I'm very happy to sit and have individual conversations with people. So thinking about the fundamentals of safe staffing and the building blocks for continuity, here you go, hold on to your hats. So we know the context for safe staffing, and we know, and I know personally because I was there way back when Northwick Park in 2005 went into special measures. Many of you weren't even midwives then, you were probably some of you still at school, I don't know. But at that point, we had all the same issues in that service that we're grappling with today. Potentially they've got worse because of the pandemic, but actually all the issues that we read about in the Northwick Park report, that we read about in the Morecambe Bay report, that we've read about in Basildon and East Kent and in Ockenden 1 and 2, all those issues are still the same issues that we're facing today. And that's why we have a real strong mandate for change. So what the fundamental thing around all of this is, can we do continuity of care and have safe staffing? Well, the bottom line on all of this is you either have safe staffing or you don't. So if your service is short of midwives, it's short of midwives. It's not the model of care that changes your situation. It's the fact that we didn't know, or we, meaning the great and good, didn't know how many midwives were required in the first place. So I want to just start us off by thinking about how would we know if our staffing is safe. And the first thing is that we have accountability mechanisms. So every year, and we have at least Sarah here, who's going to speak to you next, who is a director of midwifery, and what she has to do, and what I used to do when I was a head of midwifery, is we had to write a board paper explaining what we thought the right number of midwives was, and could we have that number please to the board, and they'd agree to fund it or they wouldn't. We also had tools and mechanisms in place, Birth Rate Plus, along with a nice safer staffing. We've now got the NHSEI toolkit and the live acuity tool. So we've got various mechanisms to count our staff, and then what we do is we triangulate that with incidents, complaints, red flags, sickness and maternity leave, to see if all that marries together to say that our staffing is as it should be. So that's how you do it, whether you're doing a traditional model of care or whether you're doing continuity. It doesn't really matter. Those principles and that governance has to stay the same. But people have asked, oh, well, surely we need to have more, we need to have this, we need to have that. So we need to think about how we set our establishment. And the first thing is thinking about the Birth Rate Plus. At the moment, the only mechanism we have, or the only tool we have in our cupboard, so to speak, to calculate how many staff we need is the Birth Rate Plus methodology. Now, that has been in place since around about 1996, and we still use it today. And you'll be aware of the Ockenden report. It has now asked us to review that, because that's a good 20 years, at least 25 years almost of it being in place. It's good that it's being reviewed, and there is a committee now in place that is reviewing that. But at the moment, that tool helps us assess our establishment. Our establishment means how many midwives do you need in your books to provide safe care. And when you're doing that, you consider not only how many women you care for, you think about the acuity of the women. But what we know from the King's Fund, and this has cropped up in various other reports as well, it's not necessarily more we need, although that might be the case, particularly at the moment through the COVID situation. What we need to have is the right people in the right place at the right time, giving the right care. Because you could just layer in more and more and more and more people into one place, and that deals with that, but it doesn't deal with the bigger picture, and it doesn't take into account the public health work that we do. And actually, as Turner discovered from Southampton University, actually, we don't have a clear evidence base. So all this furore and stuff that's going on around staffing, which we all need to understand because we're all midwives working in a clinical context, is that we actually don't have all the maths and all the understanding. So when we do our calculations, when we think about what our staffing needs to look like, our directors of midwifery in particular, but actually all of us can contribute to this, should be using our professional judgment. So when I was a head of midwifery and I was in a room somewhere and we were thinking about so-and-so hasn't turned up or we're short on our template, I would say to my midwives, my band 7s in particular, does this feel right? And at what point does it feel right? Because actually you know what feels right and what doesn't feel right. So you've all got a part to play in helping us understand this better. Now, how does this apply to our vision of getting to default position continuity of care? Well, you will know that what we're recommending is that because of the problems and because of the issues we're facing, we are now suggesting that we change the way we deliver our services. So in the past, everybody rocked up and they went through almost on a conveyor belt. You book, you see this midwife, you see that doctor, you go to that place, you go to this place. And what we're saying is, this hasn't done the job. What we need to do is go back, look at our evidence, and we need to do something completely different to stop the context that I talked about at the beginning. If we want to stop Northwick Park and Shrewsbury and Telford and East Kent and Nottingham is now next in line, I seem to think, we want to stop all that carrying on and carrying on and carrying on. We have to change the service delivery model. And that is what we talk about when we're talking about continuity of carer. So it feels tricky, and it is indeed an extremely complicated thing to do. But if we don't do it, we'll just have more and more and more and more of the same, and we'll be very sad. So here, what we're going to do is reorganise our staff into groups of midwives that care for the women. And we know the women, and we know it's that relational intervention that will make a difference. And I won't read all the rest of that out. You can have these slides. But in order to do this, we have to think differently. It means we've got the same number of women, we've got the same number of midwives. How do we work in a different way to achieve our ends? And as Einstein said, keep doing it over and over again the same way. It means we'll get the same results. So we'll have, we'll just have the same results happening over and over again. So if you're going to build a building, you have to start out with what does the finished blueprint need to look like. So here you go. If you like pictures, have a look. If you hate pictures, look away now. But you've got your teams, you've got your linked obstetricians, you've got band 7 oversight, you've got a core, because you'll still always need a core that's always going to be about 45 to 55% in your building. You're still going to have your specialists. Each team will have around 6 to 8 midwives. One of them will probably be a band 5 because we know from experience that band 5s have the best possible outcomes when they work in that way. And where possible, an MSW is helpful. And if you're doing enhanced teams, you can get extra money for that. If you are in a large complex hospital, you will think about having maternal medicine teams. So in order to do this, we need strong foundations for all models of care. And I'm going to focus today on the safe staffing, but actually you do need to do the other things like the engagement, the linked obstetrician, you need a standard operating policy and all those things. Now I'm going to give these slides are now in the conference and you can read all of this in detail, but if you don't put these things in place first, when you go to roll out your teams, you'll run into difficulties. So the teams that are running well, and you can read about that in the conference blog that I wrote. I think it's coming out in the blog, isn't it, today? There's an example of a service that's done it well. They put the building blocks in place, they followed the toolkit, and they are now at 85% continuity with a plan to get to 100% in the next couple of months. Now, if you don't follow that, you'll run into difficulties. And so that's why we are, I'm taking every opportunity to talk to people about how this needs to be done. So in a standard model of care, and this is just an acuity tool from a service with 2 sites, you can see, if you look in the middle bit, midwifery safe staffing, running on a standard model, you've only got perfect staffing, which is that middle one, about 20% of the time. Sometimes you've got loads more midwives in the building, and sometimes you have not enough midwives in the building. And the whole thing around that is because you don't know how many people are going to come through your building. Yeah, any time. Good. I can see you're shaking your head, and that's absolutely true. As I was a head of midwifery, I planned on 22 births a day. That could be 30, or it could be 16. Who knew? And that's why this model doesn't work. But when you go over to a continuity model, suddenly every single woman has a midwife available to her all the time. And as a consequence of that, doesn't mean all midwives have to be available all the time, but it means a midwife is available to that woman all the time, and that will make the service safe. But you're doing it with the wider team and the core. So that's the thing that makes a massive difference. So we know that this current provision and the way it works at the moment doesn't hit what we need it to hit. So we need to do it differently. Now, I can go into all the details with you, but I won't, and I'm not even going to read this entire slide out to you, but this is a condensed version of the toolkit, and I'm very glad to tell you we are about to launch a modernised version of it, which will be so much easier for everybody to use, because at the moment it depends on you remembering what the maths is and what you're supposed to be doing. But we're getting it to a point where you won't need to do that. But essentially, what you do is you draw out your current position, you decide what needs to be recruited before you start, and you start your recruitment programme, and then you agree, what do I need? What is my ratio for my intrapartum care? What is my ratio for my community? And you stick to those, and then you roll out your waves. So any given time, wherever you are in the system, you know you're safe, because you know you've got the right staff in the right place at the right time. And it's all drawn out, so nobody's confused. And actually, as you follow this model through, you will see that there is, with every iteration and with every wave, there are always more people available to you for intrapartum care. And all of that's available through the toolkit. And just in case you wondered, this is another bit about staffing. RCM and Birth Rate Plus calculated, this was pre-COVID, but it doesn't really matter, it's the principle that counts, based on an average ratio of 1 to 24.1. You need between 24,000 and 24,900 midwives. That was what their calculation was. When you apply this methodology, you'll see here that the answer comes out as roughly the same. So there will be services that need slightly more, some services need slightly less, but actually it, roughly speaking, works out the same. Working patterns. People always ask about this, so I thought I'd throw that in. The maths is, if you go for a shifted system for continuity, we can see why people want to hang on to those shifts, because it means that you've got a greater knowledge of what you're going to be doing. You'll spend 2 days out of your 3 days in the delivery suite, effectively is what it is. You'll have no time for creative caring, and you probably won't have time for all those extended relationships that make a difference. So, for example, Darlington and Durham, which was the picture I just showed you before, they've got 5-6 teams in play at the moment. Their smoking rates have dropped from like 40% to about 10%, and their breastfeeding rates have doubled. And the thing that the midwives say made a difference is because they were free to have time with the women. So the woman that needs an hour gets an hour, and the woman that needs 10 minutes gets 10 minutes, and anything else in between. And you've got that choice because you're working autonomously. If you work in a shifted system, you're then shoveled into that last day, you've got to bang through everything else, and you will not achieve the relational intervention that we are hoping to. And that's why we don't think it's good. The other thing to say about it, dare I say this, is 12-hour shifts are miserable. When I've worked clinically, I normally have a lovely time when I birth this woman. She comes in, I'm fresh, I'm happy, I give her everything, I love her, it's all wonderful. We have a lovely water birth, we're in the pool, out the pool, dancing around the room, all the rest of it. A bit like these ladies are going to tell you about in a few minutes. It's gorgeous. If you then said, Trixie, give that same thing to the next woman for the rest of your shift, I can't. I gave the first woman everything I had, from my heart, from my brain, from my body. I need to go down and lie down. And now I've gone home high as a kite because I'm really happy. So when we hang on to our shift systems, what we're hanging on to is, you remember the last person you cared for. So everybody is, maybe not everybody, but nearly everybody is a good midwife. We all come in, we know what to do, we know how to do it, and we want to do our best. We come in the morning and it's great, but we remember at the end of the day the last person we cared for, and by then we're running on empty, we're running on fumes, we may not have even been to toilet today, never mind even having a sandwich, and therefore we struggle. So that is why we don't think you should do shifts, and instead, oh hang on, running ahead of myself here, what we suggest is that you do the the autonomous working model, but that's, some people call it an on-call, but it's not an on-call like anybody's known it before. You're doing your hours, but what you're doing is you can plan your birth availability 6 months in advance, and it won't change. So you can plan your life around it in the same way as you would have planned a night shift. And so it shouldn't be so difficult. Now, I do need to just mention this bit, don't I? Because it's the elephant in the room, the safe staffing and continuity. So we started talking about this at the beginning, how we've always done it. And with the Ockenden and with the letters that have come out, how do I know that I should carry on my teams or not? Well, the first thing is you need to consider your baseline, which is your board paper. What did you tell the board you need, and how far are you off that? Now, that wouldn't be you guys, but it's about what your boss would be, or the director of the will be thinking about. Now, at the moment, we've still got Birth Rate Plus, so everybody's carrying on doing Birth Rate Plus. We're still using all the same methodologies that we're still using. It's all under review, and something new might come out, but we'll tell you about that, and we'll probably get invited back, hopefully, she said with a smile, to explain that when it comes out. But at the moment, this is what we're using. It's the best evidence we've got, and so we're going to carry on with it until we have something new. And we should be constantly reviewing our staffing and our recruitment plans. And the question should be, before any service changes anything, is what's changed? When I put those teams into play, what changed between last month when I put the teams into play and today? And if nothing's changed, you don't have to stop, because you've already taken the view that it was safe to carry on. However, if you did identify there was an issue, it's a board issue. It's not something that anybody should be carrying on their own because it's so big. And what we're suggesting is that people use that tool. You know, the picture that I showed you with the Excel spreadsheet. Use the tool to calculate safety or not safety, because stopping teams and moving teams around does not necessarily make a service safer. So if you stop one team of 7 midwives, what you would be doing effectively is increasing your template in your hospital, in your acute section by 1, but you'd then have people both coming in for birth that wouldn't have a midwife, and also all those people that need their community care without a midwife. So you wouldn't be necessarily better off. And that's the maths that needs to be understood and asked about. I think one of the key issues that people are very interested in is, what about the band 5s? And so what we're saying to people around that is, until there is further information available, everybody needs to carry on as they're doing. And you may have known, who are students in this room? Is there lots of students? Yeah, I thought there might be, because you're thinking, what the hell is she telling us about calculating our staffing for? It is important, students, one day you'll be in Sarah's position as a director of midwifery, and you need to understand it now, so you understand how it all comes together. But all of you will have got a letter from the NMC, didn't you, about, in order to qualify, you need to be able to still do continuity of care. That is still in the standard. Nothing of this has been taken away. And so there will be further advice around the band 5s. That's what I wanted to say. And then finally, we have to think about equity. So we know, because we've got 3 Cochrane reviews, tells us we improve outcomes, and in particular for people in unequitable situations. So people who are Black, Asian, mixed race, people who live in the bottom decile of population. And the Equity Act of 2010 says you cannot take this away. So potentially you're opening yourself up to litigation if you did do. So it is worth bearing all this in mind. And of course you have to evaluate what you're doing, but we won't spend too long on that. There are lots of examples of good practice in the country. James Paget features in the blog, as I've said, but one really interesting one that you might all be interested in is in Milton Keynes, for example, and this was before Omicron that this little picture was made, but their sickness was at 1%. James Paget's sickness is at 1%, and you lot are smiling, your sickness is at 1.1%. So we've got someone in the room that can demonstrate that what I'm saying is true. Working in the model with continuity actually reduces your sickness. And if you actually have people coming to work, that changes the complexity of everything, doesn't it? I used to have 6% sickness, just to give you a kind of a clue as to what we're talking about. Now then, we're asked to save babies' lives. We're asked to increase smoking. No, we're not. We're asked to increase breastfeeding, and we're asked to reduce smoking. We're asked to do all these things that improve mental health. But actually, without a vehicle to do any of these, we can't do it. And continuity is the vehicle to deliver these things. And therefore, we all of you, and you all, so many of you put your hands up, you're all students, we need to remember what we're here for. So the hand that rocks the cradle rules the world, does it not? I always say even Hitler had a mother, and maybe if Hitler's mother had a better midwife, he wouldn't have Hitler. Or putting it into modern parlance, it could be Putin. Equally, people have got slightly interesting ideas of the world. It's true, it is true. What we are doing here, and Jenny and I were just joking about this before we started, what we're doing here, ladies, I think there's only ladies in the room, what we're doing here, apart from Stuart, is we're changing the world. So when we get that mother and baby dyad healthy, which we can do far more effectively through continuity because of that relational intervention, we make that woman healthy. We stop that person dropping dead at age 60 or to age 20 or even of a heart attack unnecessarily. We know that the science is all there for that. So what we do makes a significant difference to the entire population of the world. The other thing we do is we improve mental well-being. And we know that mothers that are not depressed read to their children, talk to their children are then ready to go to school. And those children then are not the problem child that they could have been. And they're good to go. I think that's telling me I'm finished.